Hello, I'm Larry Levitt from KFF. Welcome to the inaugural episode of the new series I'll be moderating, the Health Wonk Shop. Roughly once a month, we'll be diving into timely and complex health policy topics with experts from a variety of perspectives. Today, we're talking about the future of telehealth beyond the COVID pandemic. Of course, we're not exactly beyond the pandemic, at least not yet. Telehealth use exploded into the stratosphere in the early months of the pandemic. While the trends have since returned closer to Earth, there is still much more virtual care now than before COVID. Our recent analysis with the electronic medical record company Epic found that about 8% of outpatient visits are now virtual, up from almost zero before. Telehealth has been helped along significantly through various flexibilities provided by state and federal policymakers and insurers. How long those flexibilities will persist beyond the public health emergency is a big question mark right now. And where we go from here has potentially big implications for cost, access, and equity. We're joined today by an impressive group of experts to discuss all this. Kate Berry is Senior Vice President of Clinical Affairs and Strategic Partnerships at AHIP, the insurance trade group. Krista Droback is Executive Director of the Alliance for Connected Care. Cincy Hernandez-Cancio is VP for Health Justice at the National Partnership for Women and Families. And Ativ Mehrotra is a physician at Harvard Medical School and Beth Israel Deaconess Medical Center. If you have questions at any time during the show, submit them through the Q&A button on Zoom. We'll get to as many of them as we can. And note that this session is being recorded and an archived version should be available later today. Now, Krista, let me start with you. Can you explain briefly what flexibilities have been provided to make telehealth more accessible during the pandemic? And what of those flexibilities have been extended in Congress's recent budget action?
Thanks, Larry. Thanks for having me. I think the most important one was the Medicare flexibilities that were granted during the pandemic. We have in Medicare, under normal circumstances, a restriction on who can use telehealth. You have to be in a rural area and you have to be in an institution. Congress lifted those restrictions. And as a result, in 2020 alone, we had 28 million visits by Medicare beneficiaries. That compares to less than 350,000 visits in the year prior, in 2019. So not only is that important for seniors, but it also sends a market signal because prior to the pandemic, employers were much further ahead than Medicare in terms of offering telehealth. So on the commercial side, employers were able to offer discounted telehealth services to people with health savings accounts. There are 35 million Americans in the commercial market with health savings accounts. They were able to access telehealth before the deductible. And then a couple other big ones were new kinds of practitioners were allowed to use telehealth. So speech therapists, occupational therapists, physical therapists, those were previously, at least in Medicare, not permitted to bill for telehealth. The DEA was loosened their restrictions on in-person visits prior to controlled substances, certain controlled substances being used over telehealth, and that was a lot for behavioral health. And then there are a few other, audio only was the other one I want to mention, that at least in Medicare, audio only services could be reimbursed. So I think those are the highlights.
And these flexibilities generally end when the public health emergency ends, which now runs through mid-April, although the expectations are that it'll be extended at least once more. In the budget, Congress extended it beyond the public health emergency though, right?
Correct. For 151 days, which is about 5 months. And the reason for that is they were trying to align all the policies that were extended. So there was an increase in Medicaid reimbursement for the territories. And that was another extension that they aligned with the telehealth extensions. I will say, Larry, that the reports that were required by Congress, MedPAC has to do a report, and the HHS Office, the Inspector General, also have to do a report. Those are not due until June of 2023. And I do not believe that Congress will make permanent changes to the law without real analysis by MedPAC or OIG. So our expectation is that the next action that will be taken will be another extension. And then once those reports come out and more peer-reviewed analysis comes out of what happened during the pandemic, then we can do, then we'll lobby on permanent changes.
Well, daring Krista to predict what Congress is going to do, but but I hear you. So Ativ, one big challenge here is that doctors are licensed state by state. We're here talking on Zoom across state lines, but that's not so easy when it comes to virtual medical care. What's been happening during the pandemic around medical licensure and telehealth, and what do you see as the options moving forward?
Yeah, a lot of changes in that space. Larry, just to kind of make sure we're all on the same page, for hundreds of years, for more than 100 years, the way it's worked is that I, as a physician, need to be licensed in where the patient is located. So when patients came to see me in clinic, it was no big deal. I was always licensed there. During the pandemic, all of a sudden that became a very new issue, that patients that I cared for in another state, I wasn't licensed in that state. What happened is almost all the states in the US made a temporary change at the start of the pandemic saying a patient in our state can be cared for by a physician in another state will have licensure reciprocity. And so early on in the pandemic, Americans from all over the country started having telemedicine visits with physicians in another state. In the last year, starting in the spring of last year into the summer of last year, a lot of those temporary expansions started to lapse. And there was a lot of frustration among Americans because they were used to now having telemedicine visits to a physician in another state, and all of a sudden they couldn't. They would get an email from their doctor saying, you need to be in my state if I'm going to care for you. And so they had to now go to the office or very awkwardly go to a rest area, cross over and pull into the state and have a visit. And so that new situation, a new issue that has arisen, has driven a lot of debate, both at the state level and at the federal level, about what can we do to address the Americans' need to have out-of-state telemedicine. And that's a very active area of debate.
And do you anticipate, one option is federal licensing of doctors. That seems like a bridge too far, but what are some of the more intermediate options that might be considered to ease this, once the pandemic eases?
Yeah, so there's a wide variety of options. I'll touch upon a couple of them. The first is to simply do what was the situation early on in the pandemic. A state would pass a law saying that a citizen of this state can get a visit from a physician in another state as long as they're licensed in some other state. Automatic reciprocity is what we describe that. And several states have pursued that strategy already. A next step would be there's interstate medical licensure compact, which is a compact around more than 30 states in the US, where it makes it easier for a physician in one state to get a license in another state. So those are some options at the state level. And then at the federal level, it's things such as you described, a federal licensure, or within the Medicare program specifically, as a federal program mandating that automatic reciprocity. So there are a variety of options. I agree that the last option that you described is unlikely where we will go, which is a single national license.
Larry, could I jump in here?
Yeah,
the Alliance for Connected Care is working on legislation that will instruct the Department of Health and Human Services to set up the infrastructure for sort of a driver's license type of compact that would be a national infrastructure, but would be voluntary for states to join. So the legislation, asks them to set up a process that has lots of stakeholder engagement and public comments on rulemaking, but in the end come out with something that balances patient access with patient safety and again can be something that states can join. So it's not the federal government telling states what to do or potentially interfering in interstate commerce, but actually setting up an infrastructure for them to be part of. So look out for that. It'll be introduced in the Senate in the coming months.
One last thing I just wanted to add, it's not a small number of people. In our analysis, almost 500,000 Medicare beneficiaries had an out-of-state telemedicine visit in 2021. So it's a large number of people who are being impacted by these changes.
Great. So Kate, let me turn to you. We're talking about healthcare, so we have to talk about money as well. how do you see telehealth playing out in terms of health spending? I mean, going forward, do you expect insurers to pay for telehealth visits at the same rate as in-person visits? Do you think a permanent expansion of telehealth is going to, increase health spending by adding to the amount of care people get, or save us money by substituting lower cost, telehealth visits for in-person visits?
Well, all great questions there, Larry. Thank you. And thanks for having me as a part of the panel. It's appreciate the dialogue. Well, I want to go back to something Krista said, actually, which is important to think about, which is employers have long offered coverage of telehealth. So it's not new for telehealth to be included in health benefits. And I think to expand, open it up more in Medicare, is a really important step that we would support going forward. I mean, we really believe that telehealth can deliver affordable, high quality care to patients. But we would also say that, we need to have flexibility to allow the innovation to continue, right? So we wouldn't necessarily support coverage mandates, if you will, that kind of would restrict or require certain things to be covered, or to require specific payment rates. So, we think that, we have to allow for that innovation. We have to allow for plans to design the benefits to best meet the people they serve. But I will say, the chief medical officers of the health plans and others really support continued access to telehealth. So I think that's, the most important message I would tell you. But the other point too is that, telehealth doesn't necessarily require the same level of intensity, the same level of physical infrastructure. So, we wouldn't think that you should have facility fees if there's no facility involved. If the doctor's at home and the patient's at home, we ought not to be paying facility fees. And we do think that value-based arrangements are going to make it much, align the incentives to allow for the right care to be delivered in the right setting. So, we want to make sure that people get in-person care when they need it. But there's a lot more happening in a virtual environment than we probably ever thought would happen. And that will probably be the case 5 years from now, too, that things are being cared for virtually that we didn't know was possible.
Larry, I'm sorry I keep jumping in. I just want to mention that 85% of people who had a telemedicine visit during the pandemic so far had it with their own provider. So they're not, it's not these virtual only providers that are dominating the market. It is mainly primary care physicians or hospital systems that have brick and mortar. And so we don't have a position on this particular parity issue. I do think it's important to note that this perception that it's, virtual only that is dominating hasn't borne out in patient surveys.
Thanks. I definitely want to come back to that, but want to bring.
I just wanted to add too. Sorry,
sure,
Larry.
No.
I totally agree with that point, Krista. And I think plans have contracted with what I refer to as national platforms for a long time. But I would say since the pandemic and even before, plans have been supporting their contracted providers in being able to deliver telehealth to their existing patients. So totally agree with that.
Cynthia, I want to bring you in. There are access and equity issues here as well. For some of us, a virtual visit is a whole lot easier than getting in the car and going to a medical center in person. For others, there are big barriers. People who don't have aren't technologically literate, don't have data or broadband access, have limited English proficiency. How do you think about the accessibility and equity when it comes to telehealth?
I think about accessibility and equity, especially racial and ethnic and other groups that need to often struggle with structures of marginalization. As that it's a double-edged sword, right? It's like there's a huge amount of potential if it is done right and thoughtfully, and we're designing for the tougher cases. And if we just kind of think of a one-size-fits-all model, it's very likely that you're going to end up increasing inequities. So what does that mean in the telehealth space? So first of all, you've identified the fact that there is a huge issue with broadband infrastructure in this country. And it is not just a question of like we often see reports about like where there is broadband available at any price. And that is not the measure that we need to look at. We need to look at where there is affordable broadband, and that's very, very different. So, the pandemic showed us that you can't really engage in civil society, whether it's education or jobs, to the extent that you have a job that can be remote, and healthcare without that, what really is like a necessary public utility at this point, not like a luxury, which is how it often is priced, right? And so that's one issue. The other issue, though, is that there is a lot of incredible potential for addressing a lot of the access and cultural competence and even language inequity through through telehealth, given access to broadband and the right supports that really require us thinking through the across state lines issues that were being discussed earlier, right? Like one thing that has been really clear is that let's take mental health, right? There's a huge shortage of mental health providers, let alone mental health providers that have the cultural competence, to be able to provide for particular communities. Well, you're not going to get very far in bridging that gap if you're limited to only the state that you're in, right? So, I can tell you from personal experience, at one point I found a mental health provider for my family that needed it during the pandemic in Florida, and I'm in Virginia, right? And so we need to be able to set up the systems and the infrastructures so that providers that have cultural competence, certain expertise, looking at rural areas too. Like let's say, and one of the things that we work on a lot, which is maternal mortality, is not every county has a maternal fetal medicine specialist, right? Which is what we know in many cases are going to be needed to make sure that somebody can stay healthy during their pregnancy. So it's also a question of making sure that we're setting systems up so that people can get the right care at the right time, which will require in many cases upfront investment, but over the long run will really can save lives and save well-being and save money, because people are actually able to follow up on their diabetes care, on their, high-risk maternity care, on, things that end up being very, very expensive when a person's inability or struggles to get into a car and drive to a place and get the care they need is keeping them from being able to really manage chronic conditions that over time can be very expensive. So those are some of initial thoughts about both kind of the perils that we need to plan for and the opportunities that we need to design for.
Thanks. How about privacy issues? I mean, you all are looking into my living room right now. What about with in a virtual care visit? That could present opportunities. You kind of see a person's lived environment. You see risks, potential risk to their health from that environment, but you may see other things that invade their privacy.
Yeah, and that has been a real issue also in the space of education, right? All the kids, including like my own, who were doing school through Zoom for more than a year, and we have to figure out alternatives. So for example, and this can also address the issue of like lack of broadband, right? So like if you are able to partner with a community-based organization, whether it's in a rural area or let's say, a minority, a primarily minority area, low-income areas where the person may not have the broadband and also may not have privacy at all, right? A lot of our families are multi-generational families. You don't have necessarily they may be sharing all one computer. There have been interesting examples of community health centers and other nonprofits kind of creating the space so that people can instead of having to drive 40 miles to the medical center, drive 5 miles down the road to a place where they already feel trust and understood under maybe language, accessibility benefits, to be able to do their care in that way. So we should also not only think about like 2 points, right? The doctor's office and the home. We also should be thinking about how do we build on community assets that exist, such as nonprofits and, who knows, even schools, that can be a avenue for people to get services that otherwise they wouldn't be able to get.
I'll just jump in on that. I just want to emphasize those points. From the clinical side, you can gain a lot from seeing a person's home environment. And that does have a lot of advantages. You feel like you understand and better where the patient is coming from and what might be going on with them from a medical perspective. But I do think, Larry, you raise a really key point, which is from the patient's perspective, we hear from clinicians who say, my patient just doesn't want a video visit because they don't feel comfortable for the clinician to see in my home. And then the privacy issues you discussed where, since you just described, how do you find a place where you can have such a visit? People are having visits in closets and bathrooms in their car because they're talking about sensitive issues that they don't. And this also goes on the employer side, where employers, as people are coming back to the workplace, but they're going to have telehealth visits, you can't have your mental health visit or your other visit in your cubicle. So how do we create rooms where people can go? So it's raised a whole new set of issues that we need to address in healthcare.
And I think I would add one more thing, which is very relevant, both for the graying of our population and some of the language access issues, is that there's a lot of potential for being able to bring in, whether it's a translator or a family member for a senior in their, where before may have been super challenging for the daughter to go with mom to the doctor's office, and mom doesn't remember half of what the doctor is saying because that's where mom is at the moment, right? And you can now not have to be in person to be able to bring in family members when it's needed and when it's desired by the patient, right? Similarly, now you can you can still have language accessibility as long as we're setting up platforms where there can be, safe, secure, three-way conversations. And that is also very encouraging.
Just one quick thing, Larry, to think about with privacy is we actually anecdotally have heard that one of the reasons why telemental health went up during the pandemic was because of the reduction in stigma. So people don't see you walking into a counseling appointment, and that apparently made it easier for some folks to access mental health services who may not otherwise have done so.
Right. Yeah, we also had a tremendous increase in mental health needs during the pandemic.
That's why it's difficult to parse it out. Exactly.
Yes. So we've had a ton of questions from the audience that I want to get to some. So there were several around an issue that was raised earlier around kind of these telehealth platforms, these businesses that are providing telehealth. Krista, you represent some of these. What the networks look like. Are they defined virtual care networks, or can you see any of your doctors through telehealth? Are there kind of telehealth first plans where you're required to get your primary care through telehealth? Where do you see? I mean, this has all been scrambled during the pandemic with the flexibilities, with people either unable or not feeling comfortable going to in-person care. Where do you see this going in the future? And Kate, maybe I'll start with you. I mean, from a plan perspective, do you see a rise in kind of telehealth first primary care? Do you think there will be moves to limit these networks going forward?
Well, there does seem to be a trend in that direction. I'm sure some of the other panelists can comment on that as well. There does seem to be a trend toward these virtual first. I think, you're sort of alluding to the point that, we're not at a steady state yet in terms of knowing how things are going to shake out. But yeah, that seems to be a trend. I think we would say, as others have said, that, we want to make sure that people have access to the right care in the right setting that's going to be affordable and high quality for them. So, I think we need to have options, right? We need to have the 24/7, the platforms that offer 24/7 access. And, that's an important option. We need for people's primary care providers and the people who are helping them manage their chronic conditions to be able to support them in a virtual environment as well. So I think we need to have that, the flexibility to sort of meet people where they are and to do it in an equitable way as well. So those are some of the key themes I would say.
And Ativ, go ahead. Yeah.
I was just going to jump in on that, because I think that Kate's raising some really key issues. And, just to first build off what we said before, which is that if we think about telehealth circa 2022, it is mostly brick and mortar or traditional providers providing telemedicine. But I think if we look in the future, I think it's important to acknowledge that the huge number of companies that are emerging with telehealth only options, and they may, and I think my expectation is will make up a larger and larger fraction of the telehealth that patients are receiving in the United States. And that could be a very good thing because they're offering a lot of, since you brought up the issue of mental illness, and they're, that's one of the biggest areas of growth where patients are getting new options. So I want to acknowledge their benefits, but I also want to acknowledge that they really challenge some of our existing frameworks for thinking about spending and payment and quality. Just to highlight a couple of those, we pay in the US mostly still, despite our thing, on visits. But if you download a platform onto your phone and you're having chats and you're having quick phone calls and other things, all of a sudden the paying for a visit kind of doesn't work anymore. And so we've had a big surge in trying to, different kinds of payment models, subscription or capitated models. So that's one area that's really important. And on the quality side, it's also been a challenge because the way we often ensure quality is to license the clinicians that are providing that care. But some of these platforms are innovatively using coaches, AI mechanisms, other kinds of platforms. That's a lot of software and providers. And we don't have a good existing framework to ensure for the American public that that whole package is safe and providing high quality. And so we're kind of catching up a little bit with these new kinds of platforms.
Yeah, one thing that I would encourage us to think about is, I think there's a whole other conversation that needs to happen about what does quality actually mean and to what extent do we care about the distribution of quality, not just like average quality? That's a huge health equity issue. And I would argue that just licensing is something different from actually ensuring quality. And so that's a whole other conversation. But the point here is that, because it's relatively new, there aren't a lot of patient or family-centered measures for what does quality look like in the telehealth space. And so that is a place that more work needs to be done. I don't think that given the benefits that we should be pausing, the increased adoption of telehealth because we don't have that yet. I just think that it means that we need to work on it. And I think the other point that I think is really important from the quality perspective is that we need to be very careful, especially when it comes to rural health, that we don't let the option of there being telehealth be a stand-in for what sometimes is still needed as in-person care, and that we don't end up with a dual system, right? Where some people can choose telehealth or in-person, and some people never have the choice of in-person, and we don't want that to be the result. The telehealth option needs to be at the choice of the patient, not the insurance company, and not specifically the provider, but the patient. Because I don't know, like if you've ever tried to explain to an older person like my mother-in-law how to download pictures of a grandchild online, there's some people who will never be ready for telehealth, right? And we have to make sure that we're designing systems that work for them as well.
Larry, I just wanted to comment on the business models before we move on. One of the struggles that we've had in Washington is the perception that these business models are very simple. There's a lot of complexity in how they're structured, and and you mentioned that like we represent, these direct to consumer platforms, but really, the business models are not that easy. I mean, there's not a lot of direct to consumer telehealth happening. It's integrated with insurance companies. It's integrated with health systems where the telehealth provider will actually be part of the tax ID number of the provider group within the hospital or the primary care office. And so they're acting as staff extenders. There's also software licensing. During the pandemic, the Office of Civil Rights at HHS said that FaceTime and Facebook Messenger were okay for telehealth visits. That is going to go away, and it's going to be important to have a HIPAA compliant platform. And so there's this software licensing. There's a lot of different business models that are out there, and the perception is that somehow direct to consumer dominates, which is just not correct.
So I understand we had a number of questions around reproductive health. The potential Supreme Court decision coming, which could limit or overturn Roe v. Wade, contraception, prescribing generally, virtually. And I'll open this up to the group. I mean, what opportunities and challenges might exist around, let's say, telehealth for medication abortion or telehealth for contraception?
Yeah, so that's an area that we work a lot in as, a 50-year-old feminist organization that has worked on reproductive health and rights for a very, very long time. Obviously, we are very concerned about what the Supreme Court may do in the future. We're also very encouraged by the fact that the FDA has removed medication abortion from REMS. It was completely unnecessary and inconsistent with FDA processes, other than for like political, very clear ideological reasons. And so we believe that being able to do cross-state line prescription visits and prescriptions are going to be really important for ensuring that women and people who can get pregnant can and need or want abortions are able to get them. That in addition, the rise of telehealth contraception has been something that preceded the pandemic. I don't have exact figures on that, but we also think that especially when it comes to challenges in rural areas, in particular communities, and also with ongoing defunding of Planned Parenthood, which has been a core place where a lot of people get their reproductive health needs met. Not abortion, but contraception and others, and things like pap smears, et cetera, that it's going to be you can't do a remote pap smear, but you certainly can do remote prescription for contraception. And with all of the advances also on remote monitoring, like being able to check blood pressure and things like that, we think that there's a lot of potential for, safe access to contraception and medication abortion through telehealth.
I'll just quickly jump in. We've done some sticking where Cincy was on telecontraception. I think it really illustrates some of the potential benefits, and also it's just some issues that we need to address. We did a secret shopper study of a number of companies that were providing telecontraception, and really illustrated the low cost that they can provide, easy access, cash only business, but at a price point that many women can afford. And also based on what we could do from this study on the quality side, we found that the quality was equal to what you would find in an in-person encounter. So very strong evidence, but it also does have downsides. For example, maybe in particular in terms of continuity of care. Now a woman is having, contraception from one company, but the rest of our primary care from another company. And so that also, we also want to move the U.S. healthcare system. Many would focus on a more primary care focused, improving continuity, and these new kinds of companies both offer that option and access, but also there are more providers that are taking care of patients.
We also had a number of questions about equality, and some of you touched on that earlier. And Atif, maybe I'll stick with you. I mean, there were questions about any evidence around whether, the quality of virtual care versus in-person care around how much time clinicians are able to spend with patients? Is it more time or less time with virtual visits versus in-person care?
Yeah, I think Larry, it's this kind of I almost call it a paradox. First, I should acknowledge that there have been a number of randomized controlled trials and other trials looking at where patients get either tele or in-person care, and find that in many scenarios and many clinical situations, telemedicine provides equal quality of care. And so that's been a very valuable thing. It also just acknowledged that we were applying telehealth into many applications that worked. And then during the pandemic, we started doing it for everything because that was the only option. And so I think it's also important to acknowledge that there are a lot of clinical conditions that are currently not amenable to telehealth. And we have to acknowledge that. And clinicians and patients are making that decision. I'll make two other points really quickly. The first is that there is a need. What I got asked by policymakers is, okay, it's fine and maybe equal. Does it actually improve outcomes if I offer telehealth on top of what I have? And we lack the data often in that circumstance. And then the last thing to emphasize is that this is the part that makes policymaking and life in general really hard, is things are changing all the time. What is a safe or high quality encounter via telehealth now versus in the future may be very different. And to make that super concrete, you got a mom, she's got a wiggly 2-year-old who has a fever, she's worried the child has an ear infection. Right now, via what we're doing right now, I don't think that's a high quality encounter. You're not looking in the kid's ear to see if they, what the tympanic membrane looks like. However, if mom has a device where she can take a video of the eardrum, send it off to the doc, maybe that's a very high quality encounter. And we're starting to see those kinds of technology emerge. So just the point that I want to emphasize is what is safe today may be very different than what's safe 5 years from now.
And do you think, since you talked about, literacy among patients in dealing with telehealth, what about literacy among physicians and other clinicians? I mean, you're at a medical school, do we need a training for physicians and nurses around how to conduct virtual care?
The medical field is very much an apprenticeship model where we learn from working with our senior colleagues and so forth. And so in the same way that all the physicians and nurses and every physical therapist and speech therapist have switched to telehealth, the trainees are also learning through that. So that is already happening right now, Larry. But we're still learning along the way. One of the things that we all acknowledge is that the advance in telehealth that happened during that pandemic was so rapid. It was just, a decade was, pushed into a month. And that's both a positive and a negative. The positive is we accelerated the change. The negative is that we're still 2 years in figuring out how to do this safely and correctly clinically.
Larry, I just want to jump in and say one challenge for providers is that patients have now tried it and they like it. So there is some pressure on providers to continue to offer the opportunity to have telehealth visits as part of, a continuum of care, which is why it's so important for Medicare to cover telehealth, because it's hard for a provider to invest the time and the workflow changes into having telehealth options in their office if a whole part of their patient panel is not covered. So if insurers and others want to have telehealth be a permanent option for patients, then Medicare has to cover it alongside the commercial market and Medicaid.
So, Kate, let me ask you. You mentioned earlier, that you don't think it's appropriate that facility fees be charged for a virtual visit, and we've actually seen those fees and have written about them as part of our news operation, KHN. We had a question about whether a facility fee might be appropriate for, investing in infrastructure like cybersecurity in the context of a telehealth infrastructure. Krista mentioned sort of the investments necessary. Do you, as a payer, is it appropriate to build that into the reimbursement? Is that something that is not a payer's responsibility? Is some broader societal responsibility?
I mean, I think that, again, we need to have some flexibility. We need to let this play out a bit. And as I understand it in the omnibus, I think that there was an allowance for facility fees for new sites, I believe is what's permitted there. I think the key is if there isn't a facility, then probably no. But in some cases, that may make sense. And again, as we gradually move to value-based environment where, we should have more neutrality around what the setting is. I think that is another way to think about it as well.
I would add that one thing that's important to think about is that not all providers are on the same playing field, right? And so there may be needs for, and we know this happened in primary care. There was a lot of investment that happened in primary care offices at the beginning of the pandemic so that they could provide telehealth care without any guarantees that they were going to get that any of that recouped, right? That they were going to be reimbursed for any of that. And so maybe it's not a question just of facility fees, but maybe it's just let's not pretend that once you have a telehealth platform that you don't need to keep updating it and upgrading it and training people on it and training staff on it and spending the time to train your patient on it. And how do you, for example, in the rollout, which is not a one-time thing, right? You're continuously rolling out this option to patients, right? And how do we maybe help with, working with community-based organizations to help train a senior on how to do it, or there are all these different kind of upfront investment that needs to happen that are often assumed as just everybody has it in upper or middle class white communities, and it's just not the case, and not the suburban community, because then there's also the rural aspect. So I don't know if it's an alternative to facilities fees, but we can't just think that all of that is going to be captured in a capitated system or or in individual, the reimbursement for individual visits, because there's a lot that needs to go in ahead of time.
The one thing I'll just add on to what Sissy said and others have already said is that it's very complicated from a business model with high fixed costs and low marginal costs. And I do think that really emphasizes at least my own personal perspective, echoing what Kate said, which is that mandating, from my perspective, parity or a certain dollar amount that we should provide for telehealth visits doesn't make sense to me given these complexities.
Yeah, the real answer is value-based care models. I mean, if we had value-based care models, there would be a mix of telehealth and in-person visits, depending on, what's most appropriate. I'm not saying they're not choosing what's most appropriate now, but there wouldn't be any thought about what happens with my reimbursement if I, to have a patient do a digital visit instead of a, in-person visit. So I hope that we can figure out we can crack the nut on value-based care, because a lot of these conversations then wouldn't be necessary.
Yeah, I want to second what Krista is saying, absolutely. And also put up an important flag, which is that right now, and for the foreseeable future, unless things change considerably, the barrier to entry to value-based care models is considerably high, requires a lot of upfront investment. There are a lot of small community providers, safety net, one-off, two-off providers that have a lot of cultural competence and trust by the community that simply cannot, with how things are designed right now, cannot engage in value-based models, especially any with downside risk. And so we need to figure that out. And we need to figure that out independently of whether we continue to do telehealth or not. But I think it's important to flag that it is super important for us to figure out how to make value-based care work for the harder, more challenging communities and the providers who have stuck it out with them for so long.
Well, as usual in health policy discussions, we take hard problems and we turn them into even harder problems. So we're unfortunately have run out of time, so we're going to have to leave it there. But I want to thank our panelists for a terrific discussion, and thank all of you out there for joining in, and look forward to the next Health Wonk Shop. And if you have ideas for future topics, certainly find me on Twitter and suggest them. So thanks again all.
Thank you.